Good morning. For our teaching rounds today, I'm going to be presenting our overnight admission as a clinical explainer of the source material. We're really going to explore the exact mechanisms behind this disease. We've got a classic presentation that beautifully illustrates watershed colonic anatomy, and honestly, a colitis that, in most cases, actually heals itself, as long as we support the patient correctly.
So, we'll work through 4 structured acts this morning. 1, the admission presentation. 2, a pathophysiology deep dive. 3, assessment and ward management. And 4, disposition and teaching pearls.
All right, Act 1, the admission presentation. Let's look at the timeline. Our patient is a 72-year-old woman with a pertinent history of hypertension and coronary artery disease. Her home meds, a diuretic and an ACE inhibitor, which absolutely set the stage for what happened next. 2 days before admission, she caught a viral illness, so poor oral intake, vomiting, diarrhea, leading to some pretty significant systemic volume depletion. Then her symptoms get incredibly specific. She has sudden onset, moderate, cramping, left lower quadrant pain. Literally minutes later, an urgent, intense desire to defecate. And within 24 hours, she's passing bloody stool. Now, I really want to stress here, the blood volume was modest. This is not a massive hemorrhage. You might ask why the exact order of these symptoms matter so much. Well, the sequence is purely mechanistically driven. The initial pain comes directly from the ischemia itself. That subsequent urgency, that arises from mucosal spasm and irritation. And finally, the modest bleeding happens as that ischemic mucosa actually sloughs off. Moving on to her arrival physical exam. She had mild to moderate tenderness, localized strictly over the affected left lower quadrant segment. Her abdomen was soft, and bowel sounds were present and totally normal. Notably, her initial lactate was normal, and she only had a mild leukocytosis on her CBC. The total lack of peritoneal signs, meaning no guarding, no rebound, no rigidity, and no fever, is highly reassuring. It points away from transmural infarction and tells us we have a clear window to manage this medically. Which brings us to a core question for the team. Given her left lower quadrant pain and that prior volume depletion, which part of her colonic anatomy just crossed the ischemic threshold? And why exactly is this a non-occlusive, low-flow event, rather than, say, an embolic clot?
To answer that comprehensively, let's move right into Act 2, the pathophysiology deep dive.
We have to recognize a fundamental baseline fact. The colon receives less blood per gram than any other part of the gut. It's just less metabolically active in the small bowel under normal conditions, which makes it uniquely susceptible when systemic pressure drops. Therefore, ischemic colitis is almost always a non-occlusive, low-flow disease. It's triggered by systemic hypoperfusion, things like our patient's hypovolemia or maybe sepsis, heart failure, or vasoconstrictor drugs. It is very, very rarely an embolus. Let's map out that blood supply. The superior mesenteric artery, or SMA, supplies the right and proximal transverse colon via the ileocolic, right colic, and middle colic branches. Then the inferior mesenteric artery, the IMA, takes over for the distal transverse, the descending left colon, and the rectosigmoid. And it does that via the left colic, sigmoid, and superior rectal branches. Notice how the arterial tree splits right at the mid-transverse colon. That's the precise embryologic watershed dividing the midgut and the hindgut. And this dual supply system sets up the watershed concept. Where 2 arterial territories meet, both are farthest from their origin source. Because these are the most distal branches, the perfusion pressure here is the lowest, even under normal baseline conditions. That leaves these segments with the absolute least collateral reserve when pressure drops. The 2 critical watershed zones we worry about are Griffith's point at the splenic flexure and Sudeck's point at the rectosigmoid junction. This maps out the exact step-by-step cascade, showing why our patient's 2 days of vomiting triggered her specific left lower quadrant injury. Basically, the systemic dehydration caused her colonic perfusion pressure to fall. Then, localized microvascular spasm compounds the systemic hyperperfusion, causing those watershed segments to fail first, purely because of that inherently low collateral reserve. And because the mucosa has such a high metabolic demand, it injures before the muscle does. We really need to understand this layer-by-layer colonic injury, because the specific layer that suffers explains the clinical symptoms we see. The mucosa has the highest metabolic demand, and because it's the farthest from the serosal blood supply, the injury happens from the inside out. It sloughs first, causing that early mucosal bleeding. The muscularis and serosa, they're only involved if the ischemia progresses all the way to a transmural infarction. This distinction explains exactly why modest bleeding happens early on, while peritonitis only appears much later if the deeper muscle layer dies.
Looking at the entire disease spectrum, there are 6 potential outcomes. Reversible cololopathy makes up about 35% of cases. Chronic ulcerating colitis is 20%. Transient colitis is 15%. Gangrene is 15%. Strictures account for 10%. And fulminant universal colitis is under 5%. So you can see about half the spectrum is totally reversible. But that 15% gangrene rate, that is exactly why serial abdominal examinations are absolutely mandatory.
All right, let's pull back to the bedside for Act 3, assessment and ward management. So, choosing the right diagnostic test. You usually want to start with a CT of the abdomen and pelvis. Why? Because it's fast and it rapidly excludes perforation. It'll show submucosal edema, which we see as thumbprinting, along with segmental wall thickening. Now, if we see pneumatosis or portal venous gas on that CT, it means infarction. Endoscopy, however, remains the diagnostic test of choice for direct visualization and biopsy, unless peritonitis or gangrene is suspected. In those severe cases, scoping could actually cause a perforation, so we avoid it. If we do proceed to endoscopy, the findings are quite specific. The injury is segmental, sharply demarcated, and follows a specific vascular territory. You might also see the single stripe sign. That's a linear ulcer along the anti-mesenteric border. But rectal sparing is a vital detail here, because the rectum has an incredibly robust dual blood supply from the internal iliac artery. It characteristically remains completely normal. This beautifully separates ischemic colitis from ulcerative colitis. When assessing older adults with segmental bloody diarrhea, we have to exclude 2 main alternatives. First, it is absolutely critical to differentiate ischemia from inflammatory bowel disease. IBD usually features weeks or months of symptoms in a younger demographic and almost always involves the rectum. Second, we rule out infectious colitis with stool studies, specifically looking for a prominent fever or a history of antibiotics that might point to C. diff. Mistakenly starting a high-dose steroids for ischemia because you falsely suspect IBD can be, quite frankly, disastrous. For our patient, we immediately initiated the conservative medical management bundle. This involves bowel rest, MPO initially to decrease metabolic demand. We do intravenous fluid resuscitation to actively treat the low-flow perfusion state. We start broad-spectrum antibiotics to cover gut flora that might be translocating across the injured mucosa. We also hold vasoconstrictors, like our patient's home ACE inhibitor, to prevent any further compromise of that low-flow mechanism. And above all else, strict serial abdominal examinations. The exam is our monitor. And here is a highly reassuring clinical fact to share. More than 50% of patients will resolve completely within 48 hours on these conservative measures alone. Literally, just 2 days of bowel rest and fluids is often both the treatment and the diagnostic test for uncomplicated cases. However, we have to know exactly when to call our surgical colleagues. There are 6 clear indications for an operation: bowel infarction or gangrene, fulminant colitis with systemic toxicity, massive hemorrhage, failure of medical therapy after a good trial, recurrent sepsis attributed to the colon, or a symptomatic stricture later in the course. Basically, if you see new guarding on your exam, a rising lactate, or pneumatosis on imaging, the patient has crossed into bowel infarction and they need surgery immediately. Okay, let's wrap up our patient's case with Act 4, disposition and teaching pearls. Looking at our patient's trajectory, we placed her on bowel rest, gave IV fluids, and performed serial exams every single shift. Because we caught her hypovolemia early and supported colonic perfusion, she never progressed to infarction. By 36 hours, her bleeding had completely stopped. We advanced her diet on day 3, and she was safely discharged home on day 4 with an outpatient follow-up scope arranged just to rule out any underlying malignancy and confirm complete mucosal healing. I want to leave you with 3 high-yield clinical pearls. First, pain, then urgency, then modest bleeding is the characteristic sequence. If you remember nothing else from this case, drill this precise clinical sequence into your mind. Second pearl, the exam is your monitor, not the imaging. Because 15% of patients will progress to transmural gangrene, your own hands on their abdomen every shift are literally the most critical tool you have to detect clinical deterioration. A normal lactate doesn't rule out ischemia, but your serial exams will absolutely catch a progressing abdomen. And finally, pearl number 3, a colitis that spares the rectum and respects a vascular territory is ischemic until proven otherwise. That concludes my explainer of the source material for this case. The question is, will you recognize this classic sequence on your very next shift?